So I would like to thank Professor Kuritkes for the kind invitation to talk about drug-drug interaction. But before I discuss drug-drug interaction, I would like to say a few words about the current treatment recommendation in non-hospitalized adults at high risk of progression to severe COVID-19. The NIH, CDC, and WHO guidelines recommend nirmatrelvir boosted with ritonavir and remdesivir as a preferred option, and molnupiravir as alternative option. All these treatment should be initiated as soon as possible after symptoms in onset. And it is also important to mention that the treatment guidelines no longer recommend the monoclonal antibodies as they don't retain activity against the emerging Omicron subvariant. As you can see in this table, very high concentration of monoclonal antibodies would indeed be necessary to neutralize the Omicron variants. And this medical letter published earlier this year announced that the FDA has withdrawn the emergency use authorization of bebtelovimab as it does not retain activity, notably against the XBB variant, which is now predominant in US. However, the letter mentions that antivirals can be used as they retain activity against the emerging variants. So there are differences among these antivirals. Nirmatrelvir and molnupiravir are given orally, whereas remdesivir has to be given intravenously, which can be more challenging. Dr. Olivas will talk indeed about the logistical and organizational challenges of infusion therapies. But another important difference is that molnupiravir and remdesivir have a low risk for drug-drug interaction, whereas nirmatrelvir, ritonavir can cause drug-drug interaction. So knowing that the patient at risk of progression to severe COVID-19 disease and likely to be treated with an antiviral are older people or cancer, transplant, or immunocompromised patients who are often polymedicated, the risk of having a drug-drug interaction can actually be an important determinant factor for the choice of the antiviral, as illustrated in this single-center observational study, which was conducted in Italy and which assessed the prescribing patterns of the 3 COVID-19 antivirals. And you can see that molnupiravir tended to be more often prescribed in older people, likely due to the fact that they receive more comedication and are at higher risk for drug-drug interaction. Remdesivir tended to be more often prescribed in individuals with organ transplant or on immunosuppressive therapy. And I will now provide some information about nirmatrelvir, ritonavir, and then discuss its drug-drug interaction potential. So nirmatrelvir is a SARS-CoV-2 protease inhibitor. As you know, following the entry of the virus in the host cell, the viral genome is released and translated into the viral polyprotein, which then needs to be cleaved into functional proteins by the viral protease. So nirmatrelvir inhibits this viral enzyme, whereas remdesivir and molnupiravir inhibit another viral enzyme, the RNA-dependent RNA polymerase, which is involved in the viral RNA replication. Importantly, nirmatrelvir needs to be co-administered with the pharmacokinetic booster ritonavir to ensure sufficient concentration over the dosing interval, as illustrated in the figure on the left. Thus, nirmatrelvir is administered at a dose of 300 milligrams together with 100 milligrams of ritonavir, and both are given twice daily for 5 days. It is also important to mention that nirmatrelvir exposure is increased to various extents depending on the degree of renal impairment. So the standard dose can be used in case of mild renal impairment, but nirmatrelvir dose should be halved and given together with 100 milligram ritonavir, both given twice daily in individuals with moderate renal impairment. Importantly, the label does not recommend nirmatrelvir, ritonavir in individuals with severe renal impairment. However, I'd like to mention that an adjusted dose given once daily has been proposed for people with eGFR below 30 and those on dialysis, and was found to be very well tolerated and effective in several real-world patient series. So drug-drug interaction can occur due to the fact that nirmatrelvir is given with the pharmacokinetic booster ritonavir, which is notably a strong inhibitor of CYP3A4. Importantly, inhibition occurs rapidly after initiating ritonavir, so that even a short treatment course of nirmatrelvir ritonavir can cause a clinically relevant drug-drug interaction. It is also important to know that ritonavir has some inducing properties. However, since induction takes up to 2 weeks to reach maximal effect, ritonavir is less likely to cause relevant induction interaction during the short treatment course. So I mentioned before that ritonavir is a strong inhibitor of CYP3A4, but it is important to know that not all CYP3A4 substrate will be impacted to a significant extent by ritonavir. You have represented here several substrates of CYP3A4, so you have to know that the magnitude of the drug-drug interaction depends on the fraction of drug metabolism by CYP3A4. So for a drug like simvastatin, which is exclusively metabolized by CYP3A4, you can see that the concurrent administration of ritonavir will cause a profound increase in the exposure, almost 100-fold. On the other hand, you can see that ritonavir has a modest effect on zolpidem, and this is due to the fact that CYP3A4 plays only a partial role in the metabolism of zolpidem. So the magnitude of the interaction will increase as the contribution of CYP3A4 to the metabolism increase. And you can see that the predictions are actually aligned with clinical drug-drug interaction studies, which show a 30% increase in zolpidem exposure in presence of ritonavir and a 20-fold increase in triazolam exposure in presence of ritonavir. So a good understanding of this concept is essential in order to avoid an over-interpretation of the risk of drug-drug interaction, which could prevent the use of nirmatrelvir, ritonavir in some patients that may benefit from this treatment. So for these examples, nirmatrelvir, ritonavir would be possible with zolpidem, but should be avoided, of course, with triazolam and simvastatin. So it is important to remember that medications that are highly dependent on CYP3A4 for clearance and for which elevated concentration are associated with serious and or life-threatening reaction are contraindicated with nirmatrelvir, ritonavir. So another important information is that ritonavir causes an irreversible inhibition of CYP3A4, which takes several days to resolve. We did a study where we showed that most inhibition is resolved after 3 days. So the 3-day window is important to remember, as due to the short treatment course, we have an additional option for the management of drug-drug interaction, which we do not have with the chronic use of ritonavir as a pharmacokinetic enhancer, and which is to temporarily discontinue a given co-medication. So it is important to know that it would be possible to pause statin, and without this leading to a significant without this having any harm on the patient. So remember that if you use simvastatin, you would have to stop it during the treatment with nirmatrelvir, ritonavir, and up to 3 days after the end of nirmatrelvir, ritonavir treatment. And it is also important to remember that drug-drug interaction cannot always be prevented by pausing the comedication. This is notably the case for comedication, which have a long elimination half-life like amiodarone. Furthermore, interaction with strong inducer are not manageable due to the persisting inducing effect on drug metabolism upon discontinuation of an inducer. Thus, nirmatrelvir, ritonavir is contraindicated with strong inducer due to the decrease in exposure and the related potential risk of virologic failure. So you can find information on drug-drug interaction with COVID-19 therapies in the specialized website of the University of Liverpool. You can see here the URL. So the drug-drug interaction risk comes with a color coding: red for drugs that should not be co-administered, amber for potential drug-drug interaction, but which can be managed by a dose adjustment or close monitoring. The yellow coding indicates interaction of weak clinical relevance for which there is no particular action, and green is when no interaction are anticipated. And you can find information on drug-drug interaction in the Canadian Science Table or the website of the American Infectious Disease Society or the NIH COVID-19 treatment guidelines. Now, when looking in the Liverpool website at the top most search comedication with nirmatrelvir, ritonavir globally, you can see that there is a lot of green, meaning that these comedication do not interact with nirmatrelvir. So when considering all queries, about 30% were for comedication for which there could be a potential clinical relevant interaction. So basically the amber and the red interaction. So this picture indicates that actually a lot of the top search comedication can actually be used with nirmatrelvir, ritonavir. And you can see here that a lot of the therapeutic classes do not interact with nirmatrelvir, ritonavir, or have mostly manageable drug-drug interaction, with the exception of drugs in bracket. So, for instance, you have to know that most antidepressants are metabolized by multiple cytochrome, which will actually be an advantage, as this will lead to interactions that are mitigated, as metabolism can still occur through the uninfected pathway. Thus, the interaction of most antidepressants are like of mild, of weak or moderate intensity, and therefore it is possible to co-administer antidepressant with nirmatrelvir, ritonavir. Ritonavir was shown to increase amlodipine exposure by twofold. However, the drug-drug interaction with amlodipine is easily manageable and should not prevent the use of nirmatrelvir, ritonavir. There are actually several options for the management. So you can either reduce amlodipine dose by 50% or give amlodipine every other days, or pursue the same dosage and counsel the patient to temporarily pause amlodipine if feeling unwell. Ritonavir has also been, can also potentially increase the exposure of corticosteroids. However, the probability of developing a Cushing syndrome is expected to be very low for the short treatment course. Indeed, cases of Cushing syndrome that were observed in individuals receiving ritonavir with a boosted protease inhibitor were shown that the Cushing syndrome occurs generally several weeks or even months of concurrent co-administration with ritonavir. So there are many more examples of non-problematic drug-drug interaction with nirmatrelvir, ritonavir. However, significant interaction can occur notably with opioid analgesic, antiarrhythmics, DOACS, cancer drug, or immunosuppressant, for which a careful evaluation of the risk-benefit of prescribing nirmatrelvir, ritonavir is needed. And I will now discuss more in detail some of this interaction. So let's see the interaction with DOACS and how to manage these interactions. So this recommendation can be found in the Liverpool Drug Interaction website, and the document on the right can be downloaded from the Canadian Science Table. So in individuals with atrial fibrillation on rivaroxaban would have to be switched to a reduced dose of edoxaban to allow treatment with nirmatrelvir, ritonavir. Those on apixaban would need a dose reduction of 50%, and those on dabigatran a dose reduction based also on the renal function of the patient. For individuals with venous or arterial thromboembolism, depending on the risk of clot, the DOAC would have to be switched to a low molecular weight heparin or aspirin. But in all cases, the decision to adjust the dose of DOAC or to use an alternative anticoagulant treatment would have to be made based on individual bleed and clot risk. The drug interaction between nirmatrelvir, ritonavir, and tacrolimus is also challenging. The literature reports several cases of elevated tacrolimus concentration in a transplant recipient, like, for instance, this case of a 70-year-old patient who received a 5-day treatment course with nirmatrelvir ritonavir while on treatment with tacrolimus 1 milligram twice daily. And a few days after completing the antiviral treatment, the patient presented to the emergency room with severe headache, dehydration, and tremors. The laboratory investigation revealed an extremely high tacrolimus level and acute renal insufficiency. The tacrolimus treatment was stopped and for several days, and the patient eventually recovered. So this case is not surprising, considering that ritonavir is a strong inhibitor of PGP and CYP3A4, which will result in a profound increase in tacrolimus exposure, as demonstrated in this drug-drug interaction study. So the issue here has been to maintain actually the daily dosing of tacrolimus during nirmatrelvir ritonavir treatment. Indeed, this study showed that the interaction between nirmatrelvir ritonavir and tacrolimus can be managed by posing tacrolimus during nirmatrelvir ritonavir administration. And the authors suggest to initiate nirmatrelvir ritonavir 24 hours after stopping tacrolimus, and to measure the tacrolimus concentration 2 days after the treatment completion, and to reinitiate tacrolimus on the following day at a more or less reduced dose based on the result of the TDM before going back to the original dose. And by doing this, the author observed a low incidence of supratherapeutic tacrolimus level, and there was, however, a short period of sub-therapeutic level, but which did not have adverse consequences. And finally, immunocompromised patients can be challenging to treat, as some patients can have persisting COVID-19 infection with prolonged viral shedding and or relapsing symptoms. And the literature reports indeed several cases requiring a repeated or extended course of nirmatrelvir ritonavir in order to clear the virus, like this 70-year-old patient who received chemotherapy, including rituximab, and who had persisting SARS-CoV-2 infection requiring a repeated treatment course with nirmatrelvir ritonavir, but also with remdesivir. Finally, the patient received a 26-day treatment course with nirmatrelvir ritonavir, after which he improved. The PCR became negative for the first time. So now it is also important to mention that the risk of drug-drug interaction may actually differ when administering nirmatrelvir ritonavir for 5 days versus 26 days. As mentioned in the introduction, the inducing effect of ritonavir on some cytochrome or UGT is unlikely to occur with a short treatment course, as it takes several days to reach the maximal effect. However, induction can fully develop when nirmatrelvir ritonavir is administered for a longer duration. And you have listed here Comedications for which a potential clinical relevant drug-drug interaction may occur with a longer treatment course as opposed to a 5-day treatment course. So I'd like to mention that we have developed this flow diagram for the management of drug-drug interaction with nirmatrelvir ritonavir. So the very first thing to do is to have a complete list of all the medication that the patient is taking, including over-the-counter drugs, herbals, or illicit drug. Nirmatrelvir ritonavir can be used in case of green and yellow drug-drug interaction in the Liverpool Drug Interaction website. Now, for amber drug-drug interaction, the use of nirmatrelvir ritonavir would depend basically on whether or not the drug-drug interaction can be managed outside a clinical setting. For some drugs, the patient may be counseled to pause a comedication if feeling unwell. However, for some other drugs which require a complex management, in this case, you would have to evaluate the risk-benefit of prescribing nirmatrelvir ritonavir. For red drug-drug interaction, we have seen that co-administration with nirmatrelvir ritonavir would be possible for drugs that can be paused or when an alternative non-interacting drug can be used. To help you manage drug-drug interaction with nirmatrelvir ritonavir, you can download from the Liverpool Drug Interaction website this table, which provides an overview of drug-drug interaction for a given therapeutic class and their management or alternative drugs. But drug interaction are not limited to nirmatrelvir ritonavir. I would like to say a few words on ensitrelvir. This is a novel oral SARS-CoV-2 protease inhibitors, which was approved for emergency use in Japan last November. Ensitrelvir is metabolized by multiple cytochrome, with the major contribution being from CYP3A4, and therefore can be impacted by strong inducer, which are contraindicated. Importantly, ensitrelvir is also a strong inhibitor of CYP3A4 and has the potential to increase the exposure of co-administered CYP3A4 substrate. And one key difference between ensitrelvir and nirmatrelvir ritonavir is the long elimination half-life of ensitrelvir, which implies that the inhibitory effect lasts several days after discontinuation of ensitrelvir, as you can see in this drug-drug interaction study with dexamethasone, for which a 58% increase in dexamethasone exposure was still observed 10 days after the last dose of ensitrelvir. So the time window before resuming comedication will be longer than the 3-day time window that we have seen before for nirmatrelvir ritonavir. And another difference relates to the fact that ensitrelvir is a more selective inhibitor and does not inhibit some transporter. So when looking at the drug-drug interaction profile of ensitrelvir compared to nirmatrelvir ritonavir, you can see a slight difference in the proportion of amber and red drug-drug interaction, which is explained by the fact that ensitrelvir is a more selective inhibitor and a weaker inhibitor of PGP. So in summary, the potential risk for drug interaction should not necessarily prevent the use of nirmatrelvir ritonavir and in the future of ensitrelvir, since many drug interactions are manageable with available resources, and the risk-benefit of prescribing nirmatrelvir ritonavir or ensitrelvir should be evaluated, taking into account the potential severity of the interaction, strategies for the management of the drug interaction, and their applicability outside the clinical setting. We will have some cases presented in the later on, and I hope that you will stay with us for the discussion of the cases. And I'd like to thank my colleague from the Liverpool COVID-19 team, as well as our international colleague. Thank you very much for your attention.